Hello, everybody, and good evening. Welcome to the 2020-2021 annual SAGES SCORE Resident Absite webinar. We're really excited to have you all join us. My name is Michael Awad, and I'm at Washington University in St. Louis. We're fortunate to be joined by a number of expert panelists who will be guiding us through today's program, and I'll introduce them each here shortly. We're going to be talking about kind of the format for the webinar here. I'm going to run through a couple of instructions, and then we will begin. So we're trying a new format this year of something called quizzes, and it's kind of, we found it to be hopefully an engaging format for you to use question and answer. I'm going to, again, walk you through how this will work. So on any computer or smartphone, go to joinmyquiz.com. You'll see it at the top of the screen here. It's called joinmyquiz.com. And put in the code that you see. The code is going to change with each lesson, but the current code is 812253. It will give you the option of putting your name in, or it can select a name for you. And this is, you'll be able to watch the webinar, but if you want to participate in the quizzes, then please join myquiz.com. We're going to also have a leaderboard for those of you that want to see how you're doing compared to others. So again, this is kind of new this year. We're trying it out. Yeah, terrific. I see a number of you are joining, and we're going to go ahead and I'm going to start with the instructions. You can continue to join, though, as I'm speaking. So again, this is our SAGES SCORE resident webinar for Absite review. Because of popular demand, we've actually split this into two webinars. Today is part one, where we're going to go over a number of topics, and then we'll have a part two coming up in January. All right, let's see if I can get to the next screen here. There we go. Okay, so this is our schedule for the program tonight. I'm going to be starting off with our welcome and overview, and then we'll start with our first section on esophagus, stomach, and obesity. That will be followed by general abdomen, hernia, and spleen, colorectal and anal disease, and finally small intestine, biliary disease, and flexible endoscopy. Looks like a lot of you are on the quiz, which is great. So we're going to, yeah, there we go. And we're going to move ahead. Just also want to encourage folks to consider going to the SAGES annual meeting. SAGES is the society that's sponsoring this. Many of you are familiar with it, but for those of you that don't, SAGES is the society basically for minimally invasive and endoscopic surgery. It stands for Society of American Gastrointestinal Endoscopic Surgeons. And frankly, one of the societies that for me personally has contributed the most to my academic career. I joined it when I was a resident myself, and it gave me a lot of opportunities, helped me to meet a lot of new folks. The meetings themselves are terrific. Unfortunately, this past year, like many meetings, it had to be virtual. But we hope to be able to meet in person in Las Vegas, Nevada. So please keep this on your radar. There is a great rate for trainee or candidate membership. So I hope you all consider joining if you are not already. We also want to thank SCORE, which is our partner society. SCORE, many of you are familiar with, which is the Surgical Council on Resident Education, which has really been the first and only organization to create a national surgical curriculum. SCORE has joined us in a partnership for the last several years and have provided the questions and answers that you'll be seeing today. The topics that we're covering follow the SCORE content outline that actually drives the Absite exam that's coming up in January 2021. Today, we will be covering kind of the top half of the screen. As I mentioned, abdomen, alimentary tract, some endoscopy. And then we hope that you'll consider joining us for the second part, which is on January 12, 2021, where we'll cover a number of the topics you see on the bottom of the content outline. Together, between the two webinars, we cover about 75% or more of all the topics that end up on the Absite. Again, for those of you just joining, we'll be using this plan called quizzes. You'll see the instructions to join at the top of the screen displayed at all times. Joinmyquiz.com and enter that code. You can do that on a laptop or smartphone. Also, if you have any questions in the Zoom browser, in the Zoom app, you will see a Q&A section. And the panelists and I will be monitoring the Q&A section and will be helping to respond to you that way. All right, so without further ado, we're going to go ahead and get started with our first section here. This is esophagus, stomach, and obesity. Again, I'm Michael Awad, and I'm at Washington University in St. Louis. I'm a minimally invasive and foregut surgeon. So let's go ahead and get started. And you'll see this come up on your laptops and your smartphones as well. And we'll have this showed up on the screen here too. So here's the first question. You have a 23-year-old man presents to the emergency department with chest pain of severe onset, which started after multiple bouts of emesis. He is tachycardic. Chest X-ray reveals left-sided pleural effusion and some mediastinal air. What is your next step in the management of this patient? CT with oral contrast, barium esophagram, EGD, or basically a gastrograph and swallow. And it'll give about 20 seconds for folks to read that over and answer the question. Okay. All right, a few more folks answering here. All right, just give it a little more time since this is our first round with this. All right, let's see if we want to go on to the next question. All right, sorry folks, just coming up here in a second. And good. Good. Panelists, are there anything that come up in the question and answer so far? Everybody have their technical? Okay, good. All right, so let's see how we did here. So leaderboard, this is going to be more important as we progress since we've only had one question. All right. So the correct answer is D, which is a gastrographin swallow. Um, the gastrographin, which is an aqueous contrast agent, is really the standard of diagnosis in patients with suspected esophageal perforation, which is what this question is about. CT with oral contrast can be performed where the suspicion for perforation is low, but in this case, it would not be the best next step. Barium is really only performed after using a water-soluble contrast medium if the water-soluble medium is inconclusive or non-diagnostic. The barium itself can be very injurious to the mediastinum, so if there is a perforation, it would not be the best first choice. The other diagnostic modalities are possible, but if they can have less sensitivity, EGD can be used, but has to be used with extreme caution if you're concerned about a perforation. All right, we're going on to the next question. A 30-year-old man presents to the emergency department with a 3-hour history of neck discomfort and odynophagia after eating chicken wings. Vital signs are within normal limits, and physical examination is without significant abnormality. Conventional radiographs of the neck, chest, and abdomen show no signs of foreign body or intestinal obstruction. What is the next best step in management? Barium esophagram, upper endoscopy, supportive therapy, orogastric tube suction, or CT of the neck and abdomen and pelvis with oral gastrographin. Again, we'll give about 20 seconds for folks to answer. All right. It looks like most people have had a chance to answer. Just a couple seconds there. Okay. All right, sorry, folks. All right, let's see here. Well, let's go ahead and, that's, let's see, that's coming up. All right, let's try to get that moving back up here. Okay, there we go. All right, folks, so all done. So let's see. So it looks like most people got the correct answer number 2, which is upper endoscopy. The plain films biplane radiographs identify most of the true foreign objects, like bones, and it can also show pre-mediastinal or peritoneal air. It can also confirm the location, the size, the shape of the ingested foreign bodies, and help exclude aspirated body objects. The issue, though, is sometimes fish or chicken bones, wood, plastic, or glass doesn't show up readily on a plain film. So that's something to keep in mind. A contrast exam generally is not performed because of aspiration risk, and the contrast coating the foreign body sometimes makes it hard to retrieve using subsequent endoscopy. CT scanning may be useful, but it may not detect radiolucent objects. With suspected foreign body ingestion, persistent esophageal symptoms should be evaluated with endoscopy, even if the X-ray is negative. That's why EGD is the correct answer there. All right, let's go on to our next question. All right, this one is a 20-year-old female college student who presents to the emergency department after a apparent suicide attempt. The patient drank roughly 500 cc's of an unknown liquid from her chemistry laboratory. The patient is speaking in full sentences without respiratory distress and has mild epigastric discomfort. After establishment of airway patency and hemodynamic stability, as well as placement of IV access, which of the following is the next best step? NG tube insertion, induction of emesis, oral dilution with water, glucocorticoid administration, or urgent upper endoscopy.
Because it keeps calling after 4. I should have like a PowerPoint.
All right, folks. So it looks like we're starting to find some folks show up on the leaderboard. So that's fun. Let's see here. I'm gonna restart that one. So go ahead. For some reason it didn't capture your scores, but I want you to go ahead. You get a second chance to answer. Sorry for the leaders there, but go ahead and put your answers in again. I want to make sure we capture the scores there. All right, well, doesn't seem to be capturing the scores, but let's go ahead and uh, go on to that. Yeah, so let's discuss the answer on that one. Okay. All right. So for this one, therapeutic administration of dilutants is not recommended after caustic ingestion. Forced emesis is also contraindicated, and we don't want to put a nasogastric tube down blindly. Glucocorticoids and preventing stricture is controversial, and it's really reserved for high-grade injury, if at all. Really, the correct answer is the E, which is upper endoscopy. It should be performed soon after ingestion of caustic ingestions, ideally within 24 hours to assess the magnitude and the extent of the injury. All right, next question. A 78-year-old disabled man has severe aortic stenosis and a left ventricular ejection fraction of 25%. He is on home oxygen for severe COPD. He presents with worsening of his COPD symptoms and regurgitation. Workup shows no evidence of pneumonia, but endoscopic biopsy reveals Barrett's esophagus with high-grade dysplasia. What is the best treatment option? Thoracotomy, with total esophagectomy and reconstruction, minimally invasive Nissen fundoplication, high-dose proton pump inhibitors and follow-up endoscopy, endoscopic mucosal resection, or open gastropexy. Okay, all right. Looks like so not capturing the responses just of now, but let's go ahead and discuss. I love some of these names here. Okay, so the correct answer is esophagectomy. So the best treatment for high-grade dysplasia is esophagectomy, given the high risk of adenocarcinoma. However, this man is not likely to tolerate general anesthesia because of his poor cardiac and pulmonary functional status. And so a thoracotomy and esophagectomy would not be the best option in this patient. EMR, or endoscopic mucosal resection, has been successful in treating high-grade dysplasia and stage 1 carcinoma and could be undertaken with fewer anesthesia-related complications. Nissen fundoplication, high-dose PPIs, and cholecystroplasty are not helpful in the treatment of high-grade dysplasia. So the correct answer is EMR for this one. All right, our next patient. A 35-year-old man presents with a 2-year history of severe heartburn. He undergoes a trial of proton pump inhibitor therapy for 3 months with minimal improvement of his symptoms. He then has a 24-hour pH monitoring and manometry. These studies show a percent time of 2.4% of pH less than 4 with normal motility. What is the best next step? Proceed with observation. The man's symptoms are not likely related to reflux. Perform anti-reflux surgery, such as a Nissen. Continue with current PPI therapy. Increase the dose and frequency of the PPI and observe for at least a total of 1 year, or discontinue therapy. And while we're waiting for the responses to come in, I just want to note that if you are at the joinmyquiz.com site with the code, you should be able to see the questions and answers as well as the correct answer once you respond. All right. So unfortunately, because it's not recording the score, our leaders are going to be who it was at the end of the last question, but let's go on. So the correct answer is perform anti-reflux surgery. This question is meant to describe what to do when someone has medically refractory reflux despite using medication. The persistence of symptoms after trial of PPIs does not necessarily rule out GERD. The 24-hour pH monitoring is really the gold standard. When you have findings of more than 7 episodes of a pH less than 4, or percent time of more than 1% of a pH less than 4 with normal motility, it is likely that the symptoms would be resolved with surgery. This patient has 2.4%, which indicates significant acid exposure. and also a failure of medical management if the patient has been taking PPI for 3 months with minimal improvement of the symptoms. Given the PH study findings, it's unlikely that the patient's symptoms will be resolved with increased dosing, and thus anti-reflux surgery is the best next step. All right, next question. A 68-year-old man wishes to discuss surgical treatment of a Zenker diverticulum. He presents with dysphagia, regurgitation of foul-smelling contents, halitosis, and a nagging cough. He has undergone a workup including a barium esophagram and EGD, which demonstrated a 2.5 centimeter esophageal diverticulum. What is the best operative approach? Dolman technique, flexible endoscopic repair, open myotomy with diverticulectomy, open myotomy with diverticulopexy, or rigid endoscopic repair. Okay. Francesca Armstrong remains at the top of the list. Whoever you are, congratulations there. All right, the correct answer is open myotomy with diverticulopexy. So let's discuss this one. So this patient has a diverticulum that is smaller than 3 centimeters in size, which makes an open approach an ideal approach. Patients with diverticula smaller than 3 centimeters are at risk for an incomplete myotomy with endoscopic approaches such as the Dolman technique, which involves a diverticulectomy and a myotomy performed via rigid endoscopy. Flexible endoscopic repair has the same concerns. For open approaches, myotomy is generally sufficient for small diverticula less than 2 centimeters. In cases of a persistent sac, such as greater than 5 centimeters, excision of the sac is indicated. So that would be a diverticulectomy. But when it's small like this, a diverticulopexy can be performed to prevent entry of food and secretions. Of course, a myotomy is something you always want to do. You have to treat the underlying cause for the diverticulum, and that is the division of the cricopharyngeus muscle. Okay, so our next question. A 45-year-old man with frequent abdominal pain undergoes EGD with biopsy. He is found to have a duodenal ulcer. Histology demonstrates H. pylori infection. What do you recommend as initial management? Proton pump inhibitor and H2 blocker, vagotomy and pyloroplasty, proton pump inhibitor and acid, triple therapy with a proton pump inhibitor, clarithromycin and amoxicillin, or highly selective vagotomy. Okay, the correct answer is D, triple therapy with a proton pump inhibitor, clarithromycin, and amoxicillin. Initial therapy for uncomplicated peptic ulcer disease is medical therapy aimed at reducing acid levels, increased mucosal protection, and eradication of H. pylori. In patients with H. pylori infection, therapy includes a proton pump inhibitor with 2 antibiotics, in this case, clarithromycin and amoxicillin, or metronidazole can be used, and typically 12-week course. PPIs should not be used together with antacids or H2 blockers because PPIs require an acidic environment to be activated. And again, if you have any questions, please put it in the Q&A section, and one of the faculty will be happy to answer. All right, next patient, a 76-year-old woman presents with severe abdominal pain and hypotension. An upright chest X-ray reveals free air. She's taken for laparotomy on pressors and is found to have a perforated prepyloric gastric ulcer. What is the next best step in management? An intractable with truncal vagotomy and Roux-en-Y reconstruction, a wedge resection, including the ulcer, a biopsy and omental patch closure with abdominal lavage, resuscitation and non-operative observation until the patient is stable, an intractable with vagotomy and Billroth reconstruction. All right, and the correct answer is C, biopsy and omental patch closure. The reason for this has to do with the patient's hypotensive status and on pressors. So this is an unstable patient. Normally, the optimal treatment for a perforated prepyloric ulcer would be intractable with or without vagotomy as an acid-reducing operation with the Billroth reconstruction. However, given an unstable patient, the more expeditious route is preferred. A biopsy with patch closure obtains source control and allows the patient to leave the operating room quickly for further resuscitation. In addition, there is less concern from leakage from an anastomosis created when a patient is hypotensive or on pressors. Observation is inappropriate for a patient in septic shock who requires source control. Okay, we'll do one more question and then we'll move on to the next category. All right, this is a 55-year-old man with an upper GI bleed secondary to a bleeding duodenal ulcer who continues to require several blood transfusions after 2 EGDs and an attempted interventional radiology embolization. He has known peptic ulcer disease and has been taking proton pump inhibitors. What is the most appropriate next step? Repeat EGD, Graham patch repair, GDA ligation, vagotomy, or intractable with vagotomy. Okay, so the correct answer is C, gastroduodenal artery ligation. So this patient, given they have a posterior duodenal ulcer, is likely bleeding from the GDA, the gastroduodenal artery. The GDA can be accessed through a duodenostomy and oversewn, typically with what's called a 3-point U stitch, ligating the main vessel superiorly and inferiorly and preventing back bleeding with a medial stitch. If the patient is stable in the operating room, a vagotomy and pyloroplasty would be indicated in this patient because of the known peptic ulcer disease. All right, very good. So what we're going to do here, and you'll see there is a leaderboard, and you will get a chance to proceed through the questions on your own and to review your progress and so forth. But we're going to go ahead and exit this quiz, and we're going to move on to the next one. So the next section, I'm very pleased to introduce one of my colleagues, good friend, Dr. Jeffrey Blatnick, who is one of the not just local leader in hernia surgery, but also on a national level, a leader in SAGES, America's Hernia Society, and has really set a lot of the guidelines and research in modern hernia work. Dr. Blatnick, welcome and thanks for being with us here today.
Thank you very much for having me. That's a very kind introduction and leads me to really be on my A game for you guys tonight for what we're trying to go to. So similar to what Dr. Awad went through, we'll do a similar manner of going through questions on answers, and hopefully we'll be able to keep the leaderboard working. I think we are just overwhelming the system with the pure number of participants, but we'll try again and work through it to try and answer all of your questions. While you guys are all creating clever names for the questions, I'd really like to thank SAGES. As Dr. Awad mentioned, I also joined SAGES as a resident early on. It was actually the first big national meeting that I ever went to and presented at. And it's been really influential in getting me to where I am at this stage. And so I encourage anybody who's not a SAGES member to take the opportunity to get involved as we go through.
All right, thank you, Dr. Blatnick. And just of note, when we change subjects, you do have to go and enter in a new code. So it's the same website, joinmyquiz.com. The new code will be displayed at the top of the screen at all times. 604465 is the code for the current session here.
All right, are you ready?
Nice picture. And sorry, Dr. Blatnick, we'll get the, it's just loading still. We'll get the first question up here momentarily.
I think one of the, and while this is pulling up, one thing I'll comment on based off of some of the questions that went through in the Q&A during Dr. Awad's session is, and I certainly suffered from this as I took the Absite. I always tend to overthink the questions and try to read too much into what they're trying to ask you and think of the minor scenarios. And it certainly is a way for you to get yourself kind of down a black hallway of not being able to figure out what's going on. So certainly, you know, take the information that's provided to you in the question, but don't try to overthink what they're giving to you as you think through the answers.
Blatnick should be coming up here shortly. And while we're loading, I saw a couple questions in the Q&A that were getting addressed there. Someone asked about difference between a diverticulopexy and diverticulotomy for Zinkers. A diverticulotomy is actually resecting the diverticulum. A diverticulopexy, you actually just take it and tack it upwards. That way so food doesn't go through. Okay, Dr. Blatnick, thank you for waiting. The first question is up on the screen.
All right, let's get started. So your first question is a 56-year-old woman who recently had the placement of a peritoneal dialysis catheter presents to the office with malfunction of her catheter. She reports insufficient inflow of dialysate. What is the best step for workup for this mechanical flow dysfunction? Administration of an aggressive bowel regimen, including soap suds enema. B, order a fluoroscopic catheter study with contrast to determine the tube position. C, schedule an exploratory laparoscopy to adjust the catheter position. D, obtain a plain abdominal radiograph. Or E, administer TPA solution via the peritoneal dialysis catheter. So what is the next best step, first thing that you need to do?
another few seconds.
Ready?
All right. I'm just catching up with you here. I'm waiting for our slide to advance. Okay, it looks like the system's catching up. We've got a number of respondents put their answer in. And again, you should be able to see it on your app. There's a little bit of a lag on this screen, but you should be able to see it on the joinmyquiz.com side. All right, let's see here. Dr. Blatnick, while that's loading, any
Sure.
other, oh, here we go. All right.
All right, so this is a question as we got here that I think if you have ever taken care of a patient with a peritoneal dialysis catheter is pretty obvious. Where I trained, we didn't really do any of them, and we came here to watch you and we did a lot. And so the correct answer is D, obtain a plain abdominal radiograph. And again, the thing this question harped on is the next best step, first thing that you want to do. And one of the main reasons why these catheters stop functioning is because they are mispositioned. They either flip up in the abdomen or fall out of the pelvis where they're supposed to be. So a quick abdominal x-ray will give you a lot of that information if the catheter is in the right position or not. The other big reason why a lot of the catheters stop functioning well is because of a large stool burden. And so you'll also be able to see that on the x-ray. So a quick step will give you a lot of the information you need and then allow you to determine, do you need an aggressive bowel regimen or do you need to get a diagnostic laparoscopy to reposition the tube or what's going on?
Thanks, Dr. Blatnick. There's a question in the chat about what is the Join My Quiz code? And just as a reminder, it's always going to be displayed at the top of the screen. 604465 is the current code.
All right.
Okay.
Next question. A 76-year-old man on peritoneal dialysis presents with severe abdominal pain, fever, and vomiting. His abdomen is diffusely tender on examination. What is the next best step in management? A, obtain a kidney, ureter, bladder x-ray, KUB, to evaluate the position of the peritoneal catheter. B, send peritoneal fluid for cell count, gram stain, and culture. C, perform an emergent removal of the peritoneal dialysis catheter. Or D, initiate empiric oral antibiotics with outpatient follow-up. While you guys are answering that, somebody asked for the role of fluoroscopic study. That is certainly an option that you can do. But again, if you think of the next best step, a quick x-ray for the previous question will really let you know where the catheter is positioned, which is one of the most common reasons why it'll be malfunctioning.
All right, looks like some responses still coming in. With the quizzes catch up with our overwhelming demand we have tonight. This is terrific. And again, any questions you have, please put in the Q&A and we'll be happy to address those as well.
All right. So good job. The majority of you picked the correct answer. This is a patient, you have to assume, who's been on peritoneal dialysis for a while, just based off of kind of what's given to you in the stem, who comes in with severe abdominal pain, fever, and vomiting. He's diffusely tender. So this is an intra-abdominal infection until proven otherwise, presumably based off of his dialysate. So your first step is going to be to send the fluid for culture, cell count, gram stain, and then would likely be start him on antibiotics. So if you look at why the other questions are wrong, KUB is good, as in the previous question, to show you positioning of the catheter. Emergent removal, although he may ultimately require removal of his catheter, ultimately not the best next step. And then oral antibiotics and outpatient follow-up is not appropriate for somebody who's in severe pain, fever, vomiting, and diffuse tenderness on examination. This patient needs inpatient management. All right, next question. A 30-year-old woman with intractable pain secondary to endometriosis comes to your clinic after 2 years of failed medical management. You identify multiple isolated pelvic implants during exploratory laparoscopy. What is appropriate management? A, hysterectomy with oophorectomy. B, hysterectomy without oophorectomy. C, ablation of the endometrial implants. D, direct laparoscopic application of steroid solution. Or E, imbricate peritoneum over each lesion. So this is a question that probably a lot of us haven't encountered on our day-to-day basis, but if you look at the SAGE's recommendation, GYN is certainly something that comes up on the Absite, and it's good to know some of the basic management.
All right, we didn't record any responses on this one, Dr. Blatnick, but the correct answer is showing there. Let's see.
Correct. So C is the correct answer, ablation of the endometrial implants. And so I think a couple key points to address in this question. She's 30 years old, so she's childbearing age. So you have to assume that you're going to want to do conservative surgical management, which would not include a hysterectomy with or without oophorectomy. Ablation is certainly a possibility that you can do to try and address the endometriosis, which has certainly been going on for a long time. Steroids do not have a role in the management, and imbricate the peritoneum over each lesion isn't very practical. Question number 4, a 68-year-old man with a history of hypertension and hepatocellular carcinoma status post-liver transplant 5 years ago presents to the emergency department with 2 days of persistent abdominal pain. On examination, he's afebrile and does not exhibit peritoneal signs. Labs are obtained, including a CBC, basic metabolic panel, liver function tests, amylase and lipase. An abdominal x-ray is also ordered. What else should be included in the patient's initial workup? So some of the questions would be, while you guys are thinking on this one, real quick to point out on the previous one, there is the risk for recurrent operations is certainly lower in patients who have a hysterectomy with oophorectomy. So that's something you could consider in patients who are older or post-menopausal, but certainly a discussion you need to have. All right, so back to the question at hand, number 4. The correct answer is C, urinalysis. So again, what else should be included in the patient's initial workup? This is a patient who's just presented, who we don't even have any of their lab values back or anything else to help guide you in the direction of which way you want to go. So urinalysis should certainly be added to the workup. I think the other thing to keep in mind is, given the fact that he is a liver transplant patient, means he's immunosuppressed. And so you have to take extra care of patients who are immunosuppressed, whether they're on steroids or other forms of immunosuppression, because they may not present with the normal signs and symptoms that you would expect from other diseases. So to add on to this, certainly a urinalysis. To be honest, he will probably eventually get a CT scan down the road, but ultimately it's something you'd want to do after you finish the initial workup. All right, question number 5. A 55-year-old woman with borderline resectable pancreatic cancer is taken to the operating room for diagnostic laparoscopy. Evaluation of the liver, bowel, and abdominal wall shows no signs of malignancy. Pelvic washings are sent for cytology. What is the best next step? A, mobilize the hepatic flexor and evaluate for retroperitoneal implants. B, divide the gastrocolic ligament, or I'm sorry, gastrocolic omentum to assess the lesser sac and evaluate for malignancy. C, take random hepatic needle biopsies representative of each liver section. D, perform laparoscopic ultrasound of the gastric surface. Or E, no further exploration is needed. While you guys are answering this, again, based off some of the questions, somebody asked for the peritoneal dialysis question. So going back a few things, for the patient with abdominal pain, why not operate to take the catheter out if he has peritonitis? Again, you want to really read these questions. It asks, what's the next best step? So you may ultimately need to take the catheter out, but wouldn't be the first step that you would do upon presentation.
And Dr. Blatnick, we have answer B as showing correct.
So correct. So for this one, direct inspection of the pancreas and the peripancreatic lymph node burden must be completed. Furthermore, washings in the lesser sac can be performed to allow for cytologic evaluation. Laparoscopic ultrasound can be used as an adjunct to assess patency of nearby vessels, stenosis of the pancreatic duct, endogyne lymph node biopsy if necessary. But at this stage, while you're kind of waiting for your cytology and stuff to come back, you want to evaluate the area of the pancreas to determine the amount of disease burden. All right, question number 6. A 79-year-old man on warfarin for atrial fibrillation presents with a large ecchymotic abdominal mass that crosses the midline. CT scan also shows blood in the prevesical space of Retzius. He is diagnosed with a rectus sheath hematoma. He's tachycardic and hypotensive, and he's only transiently responds to fluid resuscitation. In addition to anticoagulation reversal and blood transfusions, what other intervention would you consider next? Exploratory laparotomy with hematoma evacuation, angiography with therapeutic embolization, admission for close observations and serial H&H, continued fluid resuscitation in the emergency department, or E, discharge home. And the correct answer is B. So angiography with therapeutic embolization ultimately makes the most sense. He has what's called a type 3 rectus sheath hematoma. Treatment of patients with rectus sheath hematoma who exhibit hemodynamic instability, which this patient certainly does, should be considered for angiography with therapeutic embolization. Anticoagulation reversal and blood transfusions are obviously warranted if indicated. In the majority of patients, surgical intervention is not necessary. However, surgical drainage with ligation of bleeding vessels may be indicated if angioembolization is not available or unsuccessful. So the first thing you would do next would be angiography. Obviously, discharge home is not appropriate. He's already failed fluid resuscitation, as well as observation. So you need to intervene. An exploratory laparotomy should be reserved for a second-line therapy. Question number 7, a 47-year-old man with a history of Crohn's disease that is well controlled without steroids presents with a 13-centimeter ventral hernia from a prior laparotomy. Which of the following would be the best operative management of this ventral hernia? A, open anterior component separation with primary fascial closure. B, laparoscopic repair with intraperitoneal placement of polypropylene mesh. C, open inlay repair with bridging biologic mesh. D, open anterior component separation with primary fascial closure and retrorectus placement of mesh. Or E, open posterior component separation with primary closure. All right, so there's a couple things to consider in this question. So SAGES wants you to believe or score that D is the correct answer. And ultimately, based off of these answers, I would agree. Of all the choices there, this is the best answer. So open anterior component separation, primary fascial closure, and retrorectus mesh placement. So I think a few things you need to take into consideration with this patient. Based off of the size, he will certainly need prosthetic mesh reinforcement. So right away, that gets rid of answer A and E, which both include primary fascial closure. This is a patient with Crohn's disease. So for me, I like to avoid placing intraperitoneal mesh for somebody with Crohn's disease, even though his is well controlled. So certainly B would not be my first choice. C, an inlay repair with bridging biologic mesh. So bridging means you leave the fascial opening and you bridge the defect. And with a biologic mesh, that will eventually go away. So you're essentially leaving him with a recurrent hernia. So of all the options that are available here, D is the best answer of a component separation with primary fascial closure and retrorectus placement of mesh. You could certainly make the argument of a posterior component separation if it included fascial closure and extraperitoneal mesh placement. But it was not one of the stems.
Dr. Blatnick, well, the next question's coming up. There's some discussion in the Q&A about the previous patient where if the patient's unstable, would take him to the OR versus the IR suite.
I mean, I think that's something that certainly has changed as we've gotten further away. It's similar to non-operative management for splenic trauma and different things like that with hospitals who have easy access and mobilization of interventional radiology and different things. So I think that's a case-by-case decision, but certainly I think it makes sense since a lot of these patients can be managed without a laparotomy, which certainly would induce some further hemodynamic instability. If you can treat them with embolization first, that makes sense.
Thank you.
All right, next question. A 65-year-old woman with a past medical history notable for perforated diverticulitis, status post-sigmoid colectomy, Hartmann's pouch, and an end colostomy is admitted with a partial small bowel obstruction associated with a large peristomal hernia. The obstruction resolves quickly with non-operative management. What is the most appropriate next step? A, proceed with peristomal hernia repair with mesh on this admission. B, discharge home with follow-up with their primary care physician for small bowel obstruction. C, plan for outpatient interval peristomal hernia repair. D, ask for nutrition to educate the patient about low residue diet. Or E, evaluate the patient for possible colostomy reversal by obtaining prior operative and endoscopy reports. So somebody had asked about the previous question regarding what was the ultimate right answer. Again, the ideas to keep into consideration for that question would be extraperitoneal mesh placement because of the size, it will need mesh for repair. And so the best answer for that in that stem was going to be D, the anterior component separation with primary fascial closure and retrorectus placement of mesh. Somebody had asked, so we avoid intra-abdominal mesh placement in all patients taking steroids. That wasn't the point. It wasn't steroids, but it's Crohn's disease. Specifically for me, I try to avoid it if possible because of A, their high risk for reoperation. That was a young patient. And C, based off of the inflammatory process that's usually going on inside the abdomen. All right, so the answer for this is E, evaluate the patient for possible colostomy reversal by obtaining prior operative and endoscopy reports. So for me, when I see patients in the office with a peristomal hernia and the resident comes out to present the patient to me, the first question I ask is, can we get rid of their stoma? And for some patients, the answer is yes, and some patients, the answer is no. But that should always be your first question in your mind. Is this patient a candidate for stomal reversal? Because ultimately, Somebody who has a stoma by default will always have a hernia, and repairing a peristomal hernia is significantly harder than repairing a traditional incisional hernia after stoma reversal. And certainly for us in Missouri, we see a ton of patients who come in with stomas who are told at their hospital, you can never have this reversed. And ultimately we get them looped in with one of our colorectal surgeons who certainly is able to get them reversed many times. So peristomal hernia, first question, can you reverse their stoma in order to determine how best to proceed with management? I'll try to give you guys a little bit more time to answer these questions. We're trying to make sure we cover as many as we can. So question number 9, a 32-year-old woman whose G2P1 is nearing the end of her second trimester. She's referred by her family physician with an uncomfortable but easily reducible bulge at her umbilicus. She's anxious but well appearing. She does not report any history concerning for bowel obstruction. What is the next best step in management of this patient's condition? A, admission for emergent operative intervention, B, admission for serial abdominal examinations. C, reassurance and scheduling for an elective repair with mesh in the next 2 weeks. D, reassurance and scheduling for an elective repair with mesh after delivery. Or E, reassurance and scheduling follow-up only if needed after delivery. All right. So a couple of things, right? Same thing, you want to pick out the key points in this question. So essentially she's telling you that she's overall asymptomatic. She has it, but it's easily reducible. She's never had a bowel obstruction or any concerning findings. So that gives you some reassurance on that. She's also only in her second trimester, so now is not an ideal time to go to the operating room. And ultimately, for a lot of women who develop umbilical hernias and diastasis after pregnancies, they tend to resolve with time. So for her, the correct answer is going to be reassurance and scheduling follow-up if needed after delivery. Now, certainly you can schedule them follow-up, in 4 months just to reassure them, but there's no need for elective repair in the short term, either after delivery or 2 weeks, which would still be likely in the second trimester.
All right, and our last question for the hernias section coming up.
All right, so a 45-year-old man comes to your clinic for follow-up 1 month after an open inguinal hernia repair with mesh for an incarcerated left inguinal hernia. He reports experiencing pain along the incision. Additionally, he states that the inside of his proximal thigh is numb, burns, or simply hurts when touched. When he moves in certain ways, he gets a stabbing pain in that area accompanied by a sensation of being stung by a bee. Which nerve is most likely causing the constellation of symptoms? So there's a lot of interesting questions on that last one in the Q&A. After we finish this one, I'll answer those while Dr. Awad pulls up the next set of questions. So we'll get to all your questions about the previous pregnant patient. So this is just stuff you need to know, this question here. The nerves will be there. You will definitely get a question like this on the Absite in one form or another. And so you just kind of need to know the nerve trajectory and what's involved. So the correct answer for here is the ilioinguinal nerve. That's the one that's most likely going to give your sensation that runs across your lower abdomen and your incision. And this is patients clearly giving you signs and symptoms of what would be neuropathic pain at this point. Now, he's only 1 month out. So when you talk to a lot of people that specialize in growing pain across the country, most people would say you really want to give them, kind of 6 months of time before you would go running off to do any sort of stuff. Because a lot of these patients, it will get better with time. But this is going to be an ilioinguinal nerve injury. All right, so while Dr. Awad quickly pulls up the other things, I'll circle back on some of those questions for the pregnancy one. Somebody asked if it's described as uncomfortable, is that not considered symptomatic? I think that's somewhat subjective, but I think somebody who just says it's uncomfortable, especially in the second trimester, is somebody that would not be a good candidate for urgent or surgical intervention before she delivers. And ultimately, as the uterus grows, it ends up kind of blocking the umbilicus towards the end of the second trimester and third trimester. So a lot of times that will be covered overall as the baby grows. And I think counseling is important. You want to talk to that patient about what's going on, make sure they know the signs and symptoms to be on the lookout for. As far as would you want to repair it before she may get pregnant again, I think that's a really important question to ask when you see young females come in for umbilical hernias, whether before or after pregnancy. I think you want to know their plans for future conception, or if they plan to have more kids. I'm more inclined to fix those primarily the first time around as opposed to putting mesh in, especially if they plan to have additional children down the road. So that answers that question. Same thing, somebody else asked the same question. So first line therapy is not to use mesh if they plan to have more children. Obviously, different things depend based off of the size and different considerations. But can you explain when anterior versus posterior component separation is indicated? We could spend 3 days talking about that one. So I encourage you to attend SAGES or other surgical societies that have lots of discussions on hernias. But ultimately, some of it is surgeon practice. So my practice is primarily to do posterior component separation. I think there are some specific advantages of reduced wound morbidity, as well as the ability to get wider mesh overlap because you're not limited by the bounds of the rectus sheath as you are with an anterior component separation. So certainly I think that's something that comes with practice. A lot of institutions, you may see one or the other. So if you get that as an oral boards question, answer whatever you're most familiar with because neither one is necessarily right or wrong.
Dr. Blatnick, let's go ahead and try to load up the next section here, and we'll try to get to the remaining questions either typed answers or at the end of the seminar.
Sounds good. I'll type away on mine so everybody can see them while we're moving on to the next section.
Thank you. It's my distinct pleasure to present our next panelist, Dr. Amber Traugott from Ohio State University. Dr. Traugott is an alumna of Washington University and a good friend and colleague of mine. It was a big loss when she left and a big win for Ohio State. Dr. Traugott is a colorectal surgeon by training. And in addition to helping us with the Absite questions today, she herself is a consultant for the oral boards as well and writes questions for the oral exam too. So really pleased, a special honor to have Dr. Traugott here. Welcome, Amber.
Thanks, Dr. Awad. And I really want to thank SAGES for the invitation. I've been doing this webinar for a few years now, and it's always a lot of fun and always full of a lot of good questions. So, so I'm looking forward to using my time to hopefully do more of the same.
And Dr. Traugott, the next, sorry to interrupt, our next code is 832728. Again, at joinmyquiz.com, it is 832728. And it's always going to be at the top of my screen here in case you miss it. Okay, we've got our first question up.
All right, so our first patient is a 45-year-old man who is evaluated for a rectal polyp located 7 centimeters from the anal verge. Snare polypectomy reveals a tubular adenoma with a small focus of invasive adenocarcinoma with margins that extended to within 1 millimeter of the edge of the specimen. No lymphovascular or perineural invasion is present. Pelvic MRI reveals no abnormal findings, and endorectal ultrasound shows the biopsy scar, but without any evidence of invasion, so T0. What is the next appropriate step in management for the patient? And our choices are observation and repeat flexible sigmoidoscopy in 1 year, observation and repeat flex sig in 6 months, transanal minimally invasive surgery or TAMIS, low anterior resection, or abdominal perineal resection.
And Dr. Traugott, it's still registering all of the folks who are joining the quiz. While that is catching up to us, any other specific thoughts or tips on the Absite answering questions?
I would say, you know, there's certainly high yield topics that come up year after year, and many of those things You know, those residents who've gone before you can certainly give you some insight as to commonly tested questions or topics. I think the point's been made a little bit earlier in this webinar that the questions are not always, you know, using the most recent data that's come out in the last year that might inform our practice. And so, you know, there will usually not be, you know, two equally correct answers to choose from, but the correct answer might be one that would have been, you know, a little bit more popular of a choice 3 to 5 years ago. And so that's something to keep in mind, is that, you know, you want to choose the best answer from the choices that are given to you, and not necessarily read too much into the question to try to, you know, sort out why the answer that you think would be best is not listed. Well, how is it looking there?
Still catching up. We've got hundreds of participants, so it's I'll just be another few seconds here.
All right. And I think I'd also like to just reiterate what Dr. Blatnick mentioned earlier. You know, SAGES is really a great society to get involved with, certainly as you're a resident or early in your practice. It's a really wide network, and there's a lot of folks there from a variety of specialties, and a lot of general surgeons from all over the world, really. And so it's been a real kind of boon to my advancement in academic surgery. And so I encourage you all, if you have not become involved, it's certainly a big tent, and there's room for lots of you to get involved. All right, so our correct answer is transanal minimally invasive surgery, or TAMIS. So essentially the issue here with this question is that you had a close margin with a small focus of invasion and no evidence of any metastatic disease or deeper invasion on a staging evaluation. But with a close margin such as that, you really want to get a wider full thickness excision. And that is what TAMIS provides you. At 7 centimeters from the anal verge, it may also be a little bit challenging to do that as a traditional transanal excision, which was not a choice listed here. But that's why TAMIS is the best answer. Observing the patient and repeating their endoscopy would certainly be appropriate at an interval if your full thickness excision showed no deeper invasion. Radical excision, such as an LAR or an APR, for a small focus of invasion is probably premature until you establish that the patient has some high risk features or deeper invasion that would indicate a radical resection was necessary. And the question in the Q&A is, what is the highest one can safely reach with TAMIS? That depends on where the lesion is. So really, safely reaching with TAMIS has to be below the peritoneal reflection. Anteriorly, that's going to be lower than posteriorly if you think about the anatomy of the rectum. And so you might be able to get as high as, 15 centimeters, maybe 20 posteriorly. But if you think about, women with a lax pelvic floor and a deep cul-de-sac, anteriorly, you may only be able to get to 5. So it kind of depends on where the lesion is positioned in the anatomy of your patient. Negative margin for polyps. There are multiple definitions for that in various literature. There's not one unified definition. There is no positive margin greater than 2 millimeters, however. So if you are less than 2 millimeters, then it's going to be close. So what margin do you need? We can answer some of these questions in the text, because I do want to get to some other topics. But certainly it's stimulating a good discussion, which I will try to answer some of those later, unless some of my colleagues can feel comfortable doing so. So for our next patient, he's a 62-year-old man with a T2N0M0 squamous cell carcinoma of the anal canal, who's treated per modified NIGRO protocol, which is mitomycin, 5-FU, and 45 gray of radiation. He presents to the clinic 8 weeks after treatment and on physical exam is noted to have residual tumor. What is the next best step? So your choices are APR, an additional 14 gray of radiation, wide local excision, systemic chemotherapy with 5-FU and cisplatin, and observation with repeat physical exam at 6 to 8 week intervals. So for this question, the correct answer is observation with repeat physical examination at 6 to 8 week intervals. So the key to this question is understanding what the tumor, the time frame in which tumor response occurs for anal squamous cell carcinoma after NIGRA protocol. And it is important that you know what NIGRA protocol is, because that is also a frequently tested question. But essentially you're examining this patient 8 weeks after treatment, but they may continue to have tumor regression really up to 6 months, although in general, probably 16 weeks is going to be when most patients are going to show, at least a fairly maximal response. So at 8 weeks, you can't say that the patient is not going to have a further response or regression of their tumor. And so we wouldn't operate this early for this patient, but we would continue to monitor them and continue to make sure that that tumor continues to regress clinically up to about 6 months, and determine that has completely gone away. That includes a digital rectal exam, endoscopic exams, and groin exams. And you would continue to do that every 3 to 6 months for 5 years. And then there are patients that may have high risk clinical features, such as locally advanced disease on presentation, where you might follow them with imaging surveillance as well. Okay, so next question. 46-year-old man has fecal incontinence several times a day. 2 years ago, he had an anal fistulotomy. On physical exam, he has decreased rectal tone, but no palpable defects. The next step in his workup should be examination under anesthesia, defecography, flex sig and barium enema, anal endosonography or ultrasound, or colonoscopy. And while we're waiting for responses on the last question, if operation is needed, what operation would you offer for persistent cancer? So that would be an APR for persistent or recurrent anal squamous cell carcinoma, because the sphincters are almost always involved. And would you operate if the tumor recurs, or would you repeat NIGRA? We would operate. That's a salvage operation. In most cases, the patients would not be able to receive that dose of radiation again. And so for this question, the man with fecal incontinence who's had a fistulotomy, the correct answer is anal ultrasound. So in this patient, you really need to do a good history and physical exam initially, which you've done for this question, as it's already assumed. This patient, having had an anal fistulotomy, has already sustained a sphincter injury, and it was most likely intentional at the time. But if the fistula was complex, if it involved the external sphincter, if it was in a posterior position, if it was a high internal opening to the fistula, those are all high risk features of the fistula for a significant sphincter injury. So an anal ultrasound is the test of choice to delineate the degree of injury to the sphincter as part of the patient's assessment, and can tell you what treatments the patient might be a candidate for. All right, the next patient is a 68-year-old man with a past medical history of COPD, diabetes, and cardiac disease, who presents to the emergency department with severe rectal pain and a rectal bulge. On physical examination, you visualize the edematous circular folds of the rectal mucosa. What is the initial management choice? Use table sugar to attempt reduction, apply steady, gentle pressure to attempt reduction, perform an Altmaier procedure, perform transabdominal rectopexy with sigmoidectomy, or perform a DeLorme procedure. Okay, so the correct answer is to apply steady, gentle pressure to attempt reduction. So what you should recognize from this question is the circular folds represent a full thickness rectal prolapse. And patients will have, have severe pain when they have a prolapse in many cases. What you do want to assess when you see the patient in the emergency department is you want to make sure that their pain doesn't appear to be related to ischemia or strangulation of the prolapse. But barring that, you should attempt reduction. Table sugar can be an adjunct to your attempt at reduction in that it can help draw out some fluid and reduce edema, but that wouldn't be your initial step. Proceeding with a surgical intervention for prolapse would really only be indicated on an emergent basis if you were unable to perform a reduction. Next patient is a 26-year-old healthy man who presents with a 2-day history of perirectal pain that is worse with defecation and a small bump near his rectum. There is no evidence of bleeding. What is the most likely diagnosis? Anal fissure, perirectal abscess, internal hemorrhoids, anal cancer, or pilonidal cyst. And on the last question, the question is if the prolapse has happened greater than 24 hours ago or longer, does that change management? No, and as long as you don't see evidence of ischemia or necrosis, you would still attempt reduction. And in fact, many patients with really long-standing prolapse will just come right back out after you reduce them because their pelvic floor and their levator hiatus are so lax. For this question, the young man with perirectal pain, the correct answer is perirectal abscess. So here, the presentation is acute. It's only 2 days. It involves pain. Now, anal fissures present with severe pain as well, with defecation and sometimes with trace bleeding, but not usually with a visualized lesion or something that can be palpated, although you might see a skin tag. Internal hemorrhoids don't usually have significant pain associated with them and will have more bleeding. Anal cancer usually has a more chronic presentation than a 2-day history. And pilonidal disease, this is not the correct location. All right. And I'll try to answer what about the sentinel pile is represented by the bump? I think in this case, you have to consider that they would likely not try to trick you with the wording of the question. All right, so next question. A 27-year-old woman with Crohn's disease presents to your office because of anal pain. She reports that she's been experiencing frequent bowel movements and abdominal cramps. On examination, she's found to have a lateral fissure with rectal inflammation. What is the best treatment option for this patient? Anal sphincterotomy, increased fiber intake and sitz baths, optimized Crohn's disease medical management, topical nitroglycerin, or fissurectomy. So this question, if successfully reduced, referring to the last patient with rectal prolapse, is there follow-up needed to consider elective rectopexy? Potentially, yes, although rectopexy is not the only surgical approach to rectal prolapse, but yes, the patient should be, evaluated for their candidacy for some sort of rectal prolapse operation. All right, so our patient with Crohn's disease and anal pain, the correct answer is optimized Crohn's disease medical management. So what is described here is an atypical fissure, and when approaching your Absite, you want to consider that that when you're presented with an atypical fissure, it usually means some sort of inflammatory or infectious process and not typical fissure disease. And so you want to consider that your treatment may not be what we would normally do for typical fissure disease because it's a different pathogenesis. Typical fissures are caused by, sphincter spasm or hypertonicity, and then local ischemia in watershed areas, whereas this patient with a fissure due to Crohn's disease is due to their underlying inflammation. And so in this case, you want to treat the underlying cause, which is their Crohn's disease. Certainly, you could consider, topical numbing agents like lidocaine for comfort, or, encourage the patient to do sitz baths for comfort, but that's not going to be the best answer to this question. Next question. A 45-year-old man has mild burning anal pain for the past 2 months. He has noticed yellow-brown staining on his underwear. Proctoscopy is performed. Inflamed anorectal mucosa with purulent discharge at the dentate line is noted. Which of the following is the recommended treatment for this patient? Penicillin G, 2.4 million units administered IM. Ceftriaxone, 250 milligrams IM, and 7 days of oral doxycycline, 100 milligrams BID. Acyclovir, 200 milligrams every 4 hours for 10 days. Vancomycin enema, 500 milligrams in normal saline every 6 hours. Or cefoxitin, 2 grams IV every 6 hours, and clindamycin, 900 milligrams IV every 8 hours. So in this case, the correct answer is ceftriaxone and doxycycline. And really the point of this question is whether you can recognize symptoms associated with different types of anorectal infections. In this case, the description is most consistent with gonococcal proctitis. And whenever we are treating a patient with suspected or known gonococcal infection, we always treat for possible co-infection with chlamydia because they have such a strong association with each other. And so that regimen would treat those. Penicillin G would be for syphilis, acyclovir would be for herpes, vancomycin enemas would be for severe C. diff, and cefoxitin and clindamycin would be used for PID. Okay, next question. A 57-year-old woman presents with a large bowel obstruction. CT scan shows obstruction at the level of the mid-rectum with no dilated small intestine and with suspicious lymph nodes in the mesorectum. What is the appropriate management? Low anterior resection, colonoscopic stent placement, diverting sigmoid colostomy, diverting loop ileostomy, and NG tube decompression and serial abdominal radiographs. So in this case, the correct answer is a diverting sigmoid colostomy. And in this case, it would be a loop colostomy because the patient has a distal obstruction. Low anterior resection in this patient who is just presenting and doesn't have a diagnosis, but has suspicion for locally advanced disease or lymph node involvement, would have a better oncologic prognosis if they underwent neoadjuvant chemoradiation prior to resection. And so proceeding with that in the setting of obstruction is not likely to result in a good functional or oncologic result for the patient, at least not optimally. Colonic stent is not the correct answer in this case because the tumor is so low. In this case, if the tumor is in the mid-rectum, if you place that stent, remember you have to have a landing zone proximal and distal to it. And if the stent is so low that the patient can feel it, they would be extremely uncomfortable and wouldn't tolerate that stent very well. certainly not through a course of chemoradiation. And so that's not the correct answer in this case. But if the tumor were higher, say in the, the sigmoid, that would be a reasonable option for this patient. Diverting loop ileostomy in this case is not correct because the stem specifically told you that the small intestine was not dilated, which then implies that the patient has a competent IC valve. And so you wouldn't actually relieve their colonic obstruction, which would be basically a closed loop obstruction. And G-tube decompression and serial abdominal radiographs, again, the patient's obstruction is very distal, and so you need to relieve it more distally. So same question, except no, do you resect? Not initially if they're obstructed. They're cold. You're going to have a size mismatch if you try to make your anastomosis. And so, you'd still be better off diverting. And if the patient doesn't have, evidence of locally advanced disease, although I would argue if they're obstructed, it would be very difficult for them not to have locally advanced disease. But there would be, I guess there are potential situations where you might discover that someone has a cancer, you divert them and you operate on them. But in most cases, no, you would not resect on the initial presentation. All right, next one. 65-year-old man who has never undergone a screening colonoscopy presents to the ED with a three-day history of new onset abdominal pain and obstipation. His stools have become thinner during the past few months, and on his physical exam is a temp of 38.7, heart rate 115, and blood pressure of 90/50. CT scan with IV contrast shows a large and inflamed mass in the descending colon. His abdomen is distended and diffusely tender with rebound tenderness. After fluid resuscitation, what is the most appropriate next step in management? PET scan, emergent surgery creating a loop transverse colostomy, CT scan with oral and rectal contrast, or colonoscopy. So a lot of questions about obstructing colon cancer here in the Q&A, so we can talk about that. So in this case, again, now you have a patient who's actually unstable and has signs, of needing emergency surgery for their obstruction. And so in this case, again, you're going to take them emergently for a loop colostomy proximal to the lesion. PET scan doesn't really have any utility in a patient with signs of instability. Similarly, CT scan and colonoscopy would not be the right answer in this case. You need to relieve the obstruction and then do your assessment after that once the patient is stable.
And our last question in the colorectal section.
All right, you are asked to see a 25-year-old man with ulcerative colitis who has diffuse peritonitis, free air on chest radiograph, hypotension, tachycardia, and has failed medical management. What is the next best step? CT scan with oral and IV contrast, colonoscopy, immediate total proctocolectomy with ileopouch anal anastomosis, immediate operative total colectomy with end ileostomy, or immediate operative total proctocolectomy with end ileostomy. All right, so the correct answer is immediate total abdominal colectomy and end ileostomy. So in the emergent setting, you leave the rectum alone. And certainly a total proctocolectomy and J pouch would not be, first of all, that's a long operation. And second of all, it's a technically complex operation where you have a long staple line that would not heal well in an unstable patient. And so that would not be a good emergent choice. Similarly, doing a proctocolectomy is not good for similar reasons. And with a patient presenting emergently, you don't really need to do further endoscopic evaluation.
Dr. Traugott, while I'm bringing up the next section, I think we got to most of the Q&A. There's one left about a difference between Delorme and Altmaier.
Yes, so the data suggests that a Delorme has a higher recurrence than Altmaier procedure for rectal prolapse. A Delorme procedure is really a mucosal sleeve resection with plication of the muscle, whereas an Altmaier is a full thickness resection of the redundant rectum and possibly sigmoid, depending on how much is prolapsing. So in general, the Delorme, it's done much more frequently in Europe than it is done here. And certainly there's probably an argument to be made that in experienced hands, there are probably better outcomes. But the Delorme, I think, is most appropriate or is most frequently used in this country for short segment prolapse or mucosal prolapse. Someone mentioned that patients will need Avastin, and in the presence of stent that complicates the situation. I would say that Avastin is used in the setting of widely metastatic disease, but in the case of someone who has resectable disease who needs neoadjuvant therapy, Avastin is not used in that situation. They get 5-FU sensitizing therapy with radiation, and if they get total neoadjuvant therapy, they would get basically FOLFOX or a similar regimen, but in general, Avastin is reserved for the patients with metastatic disease. Would you bring up a rectal stump mucus fistula in the 25-year-old with UC? You can. Certainly, rectal stump blowout is not an uncommon complication in that setting. I prefer to place a pelvic drain and a soft rectal tube to decompress the rectum because usually their inflammation settles down in the perioperative period once they're diverted.
All right, Dr. Traugott, thank you so much for that excellent review of colorectal and anal Absite questions. I'm just bringing up the next question to allow it to load while I introduce our next speaker, Dr. Timothy Vreeland. Dr. Vreeland is a great colleague and really what we think of as the surgeon's surgeon. He is a general surgeon in Texas, in Fort Sam Houston, and has been a part of our course for a couple of years now. We've been extremely fortunate to have him, and he'll be leading us through our final section on biliary flexible endoscopy and small intestine. Dr. Vreeland, welcome. And the first question usually takes a little bit to load as we're getting some of the folks registered, but please go ahead and then we can chat.
Yeah, thanks, Dr. Watt. I appreciate it. It's great to be, a part of this again. I think it's a great effort, and I think it's pretty cool that there's 600 plus residents on here, and everybody's been pretty actively engaged as evidenced by all the questions and everything. So it's great. So you think the question is loaded? You think I can go?
Yes, go ahead and
Okay,
read it.
perfect.
And yeah.
Okay, so first question, a 76-year-old man is seen in clinic following resection of an obstructing jejunal tumor. It's a 15 centimeters in greatest dimension. Prior to surgery, he is otherwise healthy. Final pathology reports a 14 centimeter spindle cell neoplasm with the presence of a KIT mutation or CD117. Mitotic rate is greater than 10, and 22 lymph nodes are negative. The final diagnosis is a GIST. What's the best recommendation for this patient at this time? So observation, adjuvant therapy with 5-FU, followed by imatinib, adjuvant therapy with imatinib for 1 year, adjuvant therapy with imatinib for 3 or more years, adjuvant therapy with imatinib for 1 year plus radiation.
And Dr. Vreeland, this question is going to take a little while to load up. So.
Yeah, no worries.
Yeah.
Yeah, I can just talk about the right answer. Hopefully everybody's had a chance to answer. But so they kind of, they kind of beat you over the head a little bit that this is a GIST, right? So they say spindle cells, Spindle cells can also be benign leiomyomas. It can be leiomyosarcomas, but those are much less common. So the most common spindle cell neoplasm of the small bowel of the stomach is going to be a GIST. And then they give you, excuse me, they give you the CKIT or CD117. So most people got at least that it needs imatinib. So, this is actually, I think, a pretty advanced question for the Absite. So there was an older study a few years ago that looked at imatinib versus placebo. And then the more recent study was imatinib 1 year versus 3 years. So this question is really getting at the fact that the current guidelines recommend 3 years. And then they say 3 or more, which I also think is interesting. It's a pretty modern question. There are 2 ongoing randomized trials right now looking at 3 versus 5 or 6 years of imatinib. And most people think that the longer time you're on imatinib, the better. So other things just to keep in mind for the Absite, these 2 tables are from the NCCN guidelines. And really what I want to show you here is the risk of metastatic disease is much higher in non-gastric GIST than gastric GIST. So the easy thing to remember for gastric GIST is 5 and 5. So if it's greater than 5 centimeters or greater than 5 mitoses, and greater than 5 mitoses, so a total of 10, then you should give Gleevec. That's from all the trials basically on imatinib have required that. So if it's over 10 centimeters or over 10 mitoses alone, that's probably enough too. So if all those things add up to 10, that's enough to give Gleevec. And then the thing to keep in mind is just that the threshold should be lower for non-gastric GIST. So in this question, it was a jejunal GIST that had a really high mitotic rate, and it was 12 centimeters. Obviously this patient needs imatinib. So really the question is how long to give it. And the current guidelines are at least 3 years. All right, on to the next one. So a 47-year-old man who underwent ileocystectomy for Crohn's disease develops enteric drainage from his midline abdominal wound 14 days after operation. The fistula is pouched and more than 600 cc's of drainage is recorded. And the best next step in management includes which of the following: re-exploration, fistula resection, bedside debridement, aggressive IV fluid hydration, or loperamide?
And we're still loading up on this one,
Okay.
Dr. Breland. Well, I'm sorry. No, I think we are almost ready. Sorry. Just on the last question, what are your thoughts about neoadjuvant Gleevec therapy? What's the role of that in GIST?
Yeah, no, I think it's great. So you can get really complicated here, but there are different mutations within a GIST, and you can predict the likelihood that imatinib is going to work. So if you have the exon 11 mutation, you're going to respond to GIST or to imatinib. So for those patients, I think neoadjuvant therapy is great. There are some other mutations that are less likely to respond, and the neoadjuvant's not going to work as well. But if the resection is going to be morbid because the tumor's so big, I think neoadjuvant is great. In a mid-jejunal tumor, where it's not going to change your management, it's probably plus or minus. But it works very well, especially if you have the mutation that's going to have high response rates. So the correct answer here most people got is aggressive fluid hydration. So this is really like more of a test-taking question than anything else in my mind. So the first thing you're going to do in a new fistula is resuscitate the patient, right? So that's why this is the right answer. So would you give loperamide in a high output fistula? Sure, potentially you would. So that answer is not wrong. It's just which would you do first? The first thing you would do in any fistula is IV fluid hydration, fix electrolyte imbalances, and then look for a septic source too. So those are kind of the first steps. Get a CT, make sure there's not an abscess you need to drain, and then resuscitate the patient. And some of these, questions in the sidebar have been kind of overthinking the question, I think, for sure. So just take it at face value. So a 28-year-old woman with Crohn's disease has had 3 prior bowel resections, including ileocecectomy. She has signs and symptoms of high-grade partial small bowel obstruction that do not resolve with NG tube suction, corticosteroids, and TPN. So now you're in the OR at exploration. She has 3 strictures. One is one at the ileocolostomy, and the other is 30 and 50 centimeters proximal to the first. Her entire length of small bowel is 110 centimeters from LOT to ileocolostomy. The best management now would be local. For some reason I can't see the answers well. Local injection of corticosteroids, 3 separate stricturoplasties, a single resection removing all 3 strictures, 3 separate resections and anastomoses, or resection of the ileocolic stricture and balloon dilation of the proximal strictures. So real quick on the last one, somebody asked about, is 600 cc's considered a high output fistula? Yes, it is. Is this asking more, would you make the patient MPO and start TPN? Again, I think that's sort of overthinking it, right? The question is, what would you do next? You would give IV fluid resuscitation. So, just answer the question they're asking. Would you put that patient on TPN? Probably with a high output fistula, I think so, but that's not really kind of what they were asking. All right, so this one, they gave you that you're in the OR staring at these 3 strictures, and most people got the right answer, which is this young woman is in big trouble, right? So she's already essentially very high risk for short gut. So the criteria for the test for short gut are less than 150 centimeters with an ileocecal valve, or I'm sorry, without an ileocecal valve. So she's already under that number. Usually people say about 100 with an ileocecal valve, but she's already under the 150. So she's very high risk for small bowel. You want to do everything you can not to remove more of her bowel. So definitely do the stricturoplasties in this case. So can we do stricturoplasty? Oh, so I just want to throw in a picture for those of you who haven't seen a stricturoplasty. You basically just cut across the stricture longitudinally and then close it transversely to try to kind of make some more room in the bowel. And then you can also do these side to side, basically a bypass, and you can include it. There's different ways to do it, but this is the top 3 pictures are kind of the classic stricturoplasty. So next question, 55-year-old woman presents with sudden onset of abdominal pain, nausea, and vomiting. NG tube is inserted in the emergency department and greatly relieves her pain. A CT scan shows strong concern for internal hernia with obvious swirling of the mesentery and a closed loop obstruction. Her white blood cell count is 11,000. Her lactate is normal. She does not have peritonitis on exam. Initial management should consist of which of the following? Admission to the surgical floor, continued decompression with the NG tube and serial abdominal exams. Admission to the surgical floor, continued decompression with the NG tube for several hours, followed by enteric contrast and plain film in 8 hours. Admission to the ICU with NG tube decompression and serial lactates. Immediately proceeding to the operating room for diagnostic laparoscopy or exploratory laparotomy, or attempted reduction of suspected internal hernia in the emergency department via deep palpation of the abdomen. Okay, lots of questions. So balloon dilation is probably not going to work in that patient with Crohn's who has this chronic stricture that's failed all other non-operative management. So that's why that one is incorrect. When would you do balloon dilation? Probably not for Crohn's ever, at least not that I could think of. And then, yeah, a couple of people asked about, can you do a stricturoplasty at a previous stapled anastomosis? It's a good question, but not really relevant to getting that test question right. But yeah, I think that's a reasonable question. If you could find an area of the bowel away from the staple line, I think you could still do it. Okay, good. So everybody pretty much went to the OR here, which is good. So, the old adage was, operate on all small bowel obstructions before the sun sets or something like that. But that's really gone by the wayside. So most of these patients we will observe and do a water soluble contrast test, et cetera. But the one time that you should go, straight to the operating room without passing go is if you have high concern for a closed loop and an internal hernia. The key things here are that the white count's not reassuring. It's not very high, but that's not reassuring. And lactate is absolutely not reassuring with the internal hernia, because the venous drainage can be cut off. And so you won't drain the blood from that bowel until very late. And so the lactate rising is a very late finding with these patients. So sometimes you have to go to the OR based solely on the CT scan. And so you have to kind of know that swirl sign and be ready for that. So I just put in a picture of it. If you guys haven't seen this before, the swirl sign, it's hard to appreciate on one picture, but when you're scrolling through the CT scan, you'll see these kind of sequential images where you see the mesentery swirling. The other thing you can see often, it's hard to appreciate here, but the veins get dilated out beyond the obstruction. So the distal veins out by the bowel will be very dilated, and that's very concerning for venous obstruction. So what happens is kind of the superior mesenteric vein will twist, and as it twists, it'll get clamped off, and then you get venous congestion of that small bowel that eventually can lead to the wall dying and the bowel perforating. So that's a patient you want to take to the operating room quickly. All right. 54-year-old woman with Crohn's disease presents to the ED with 3 days of epigastric pain, bilious vomiting. She has been receiving infliximab for the past year. The patient denies passing flatus for 2 days. Abdominal X-ray shows a dilated stomach. CT scan shows a stricture at the level of the second portion of the duodenum. After 2 weeks with no improvement, the patient is taken to the OR. Which of the following is the treatment of choice? Gastrojejunostomy, total gastrectomy, duodenojejunostomy, pancreatic duodenectomy, or stricturoplasty. So somebody asked about balloon dilation and D1, D2 strictures. So now's your chance to figure out what to do for a D1, D2 stricture. So somebody asked for the exam purpose to go to the OR, but in real life, can you manage them conservatively? I would not manage a patient with a swirl sign like that conservatively, unless every once in a while you have a patient who's come into the ER a few times and you can look at an old scan and see that they kind of always have this chronic swirling of their mesentery. That one you might ignore. But otherwise, if you see that swirl sign and they have a closed loop obstruction, I would go to the OR. Oftentimes you can reduce those laparoscopically, so you don't always have to go right open. But I would go to the OR and do a laparoscopy. The other thing you can do on laparoscopy is just see if the bowel looks congested or not. All right, so a little controversy here, but most people got gastrojejunostomy. That is the correct answer. So duodenojejunostomy is just harder to do. And the problem is you're not going to decompress the stomach doing it, right? So a duodenojejunostomy, you're either not going to decompress the stomach or the biliary tree. So, if you had a stricture like right between D1 and or I guess like right above the ampulla, maybe you could do a duoj, but it just seems unlikely. And so a gastrojejunostomy is just as effective and much easier to do. And then stricturoplasty of the duodenum is generally not a good idea, just because duodenal closures are very high risk to leak. And again, a gastrojejunostomy is pretty easy to do. So it's like, why not just do that? I will say the score answer for this question was gastrojejunostomy with vagotomy. And I removed that as an option because I think that's like an old answer. Nowadays, we just do gastro-J and then put them on a PPI. But just be aware that the initial score did say to do a vagotomy with that. In real life, I don't do that. All right, a 62-year-old woman presents with sudden onset of right lower quadrant pain. She reports one episode of hematochezia after the pain started. She has never had surgery before. On exam, she is tender in the right lower quadrant, directly over a palpable mass. CT shows a target sign with a terminal ileum noted inside the cecum. What would be your initial management? Sorry, I'm trying to... Insert an NG tube, perform serial exams, repeat the CT in 4 hours to see if the intussusception has reduced. Consult radiology for an attempted air enema reduction. Proceed to the operating room for laparotomy. Attempt manual reduction of the intussusception and ileocecectomy if unable to reduce it. Proceed to the operating room for laparotomy and ileocecectomy. Consult GI for colonoscopic decompression. So somebody asked, would I typically wait 2 weeks on that patient with Crohn's? Yeah, I mean, I think you'd be pretty patient in general in patients with Crohn's. Just try not to operate on them if you don't have to. Giving steroids might resolve the stricture. So you try medical management first. Okay. Looks like it's working, tracking the answers for my section, which is good. So the correct answer is to do the ileocecectomy, right? And I think a lot of people got that. So, the difference here is this is an adult, right? So an adult intussusception is cancer until proven otherwise. So you're going to resect it. Especially this is a terminal ileum into cecum intussusception. So you're not going to have trouble identifying it in the operating room. You know what operation you have to do, an ileocecectomy. Or you could argue a right hemicolectomy to get a little more nodal harvest, but you should presume that this is a cancer of some sort that's causing the intussusception in a 62-year-old. All right, next one, a 58-year-old man underwent a laparoscopic cholecystectomy 6 months ago. Over the past week, he has become jaundiced with acolic stools. He also reports mild abdominal pain and slight nausea, but denies any additional symptoms. Right upper quadrant ultrasound shows mildly dilated common bile duct at 15 millimeters, but does not visualize the distal common bile duct. You follow this up with MRCP, which demonstrates a moderate stricture in the distal common bile duct with no evidence of biliary leakage. What is the next best step? Resection of the strictured segment followed by hepaticojejunostomy. Resection of the strictured segment followed by end-to-end choledochoduodenostomy. Endoscopic balloon dilation of the strictured segment. Resection of the strictured segment followed by choledochoduodenostomy. Sorry, I think I read the other one wrong. So there's choledochodostomy. So end-to-end bile duct repair, or resection of the strictured segment followed by a Whipple. So somebody asked about the criteria for short bowel. So with an ileocecal valve, you can have a little bit less bowel. So people, usually you read 100 centimeters. Without an ileocecal valve, you want to have 150 to avoid shortcut. Is it important to know the different types of stricturoplasty? I would say no, not for the Absite. I think the Heineke-Michalek's, the one that we showed there, is probably the classic one. All right. Yeah, so endoscopic dilation is the correct answer. So that was the most common answer. So a lot of people did want to resect that segment. So this is 6 months out from a cholecystectomy. There's no bile leak. This is not a transection of the bile duct, right? So you can presume that this is probably like a small thermal injury, less than 25% of the duct. And usually those can be managed conservatively. So you would try, and by conservative, I mean non-operatively. So you would try to do non-operative things to this first. So if you dilated it 2 or 3 times and it failed, or the patient came back with recurrent cholangitis a few times or something, then you might resect and do a hepaticojejunostomy. But you would try dilation first because that's a big operation, and you can probably get away with just dilating. Yeah, so somebody said, isn't it ileocecectomy an improper cancer resection? So not for a small bowel cancer. So you're presuming this is a small bowel cancer. Ileocecectomy is an appropriate oncologic resection for small bowel cancer. All right, during a laparoscopic cholecystectomy on a 45-year-old man, you have ligated what you believe to be the cystic artery and cystic duct. You are removing the gallbladder from the cystic plate. You notice a bile leak coming from the area where you dissected out the critical view of safety. Further examination of the operative site reveals the leak originated from a transected bile duct with a diameter of approximately 4 millimeters. Excuse me. You trace the anatomy distally and you confirm that it is not the common hepatic duct or the common bile duct, but you are unable to trace the origin of the transected duct. What is the most effective management option? Perform a cholangiography to assess the anatomy of the injured duct. Complete the procedure without intraoperative intervention and externally drain the operative site. Place a T-tube across the injured duct and place an external drain at the completion of the case. Ligate the injured duct and place an external drain at the completion of the case. Complete the procedure and transfer the patient to a tertiary care hepatobiliary center. So somebody asked on the last one if it'd be better to stent the common bile duct. Yeah, I think that's reasonable. Most GI guys would probably balloon it and stent it, but again, for the test, that it wouldn't give you balloon dilation and stenting. The point is just that you would manage it endoscopically and not operate right away. Okay, good. So yeah, most people got cholangiography. So yeah, you need to define the injury. That's the first step. If you're worried you have an injury, you need to define it. So I think one thing that's a little tricky about this is that they say it's 4 millimeters, and most people probably say, oh, that's a pretty small duct, 4 millimeters. You could probably ligate it, although not a lot of people said that, which is good. But keep in mind that a normal common bile duct can be 4 or 5 millimeters. It can be very small, and so the right hepatic duct could very easily be 4 millimeters. So you can't ignore a duct just because you think, oh, it's only a couple millimeters. You need to define the injury before you decide what to do. Now, if it's this is like a sectoral branch of the right posterior or something, could you ligate it and be okay? Probably, but you need to define the injury first before you go ligating the right duct or something like that. All right, a 63-year-old man presents with progressive right upper quadrant pain and fever of 24 hours duration. He has been admitted several times in the past 3 months for fevers, but he felt better after receiving antibiotics. 6 months ago, he had a cholecystectomy complicated by a bile duct injury that was repaired with a side-to-side choledochoduodenostomy. CT of the abdomen pelvis reveals inflammation in the porta and dilation of the intrahepatic and extrahepatic bile ducts. He's tachycardic. He has a fever. His white count is elevated. Amylase of 10, bilirubin of 5.3, AST and ALT are elevated. What is the most likely diagnosis? Acute pancreatitis, sump syndrome, intra-abdominal abscess, anastomotic leak, acute hepatitis.
Dr. Reland, there was an interesting question in the Q&A about test taking tips for long question stems.
Yeah, so I learned, like studying for MCAT, to read the last sentence first. So I always do that, especially if I'm crunched for time, which the Absite is not really like, you're not crunched for time. So I would just say slow down and take your time on the Absite. I mean, very rarely are you running out of time, but one strategy is to, because look at this question right here, right? There's a super long vignette, and then they want to know what the diagnosis is. Whereas sometimes they'll ask, what's the next test or what's the operative intervention? And so sometimes reading the last sentence first sets your mind right for the vignette. So I think that if you're running into trouble with things like that, just read the last sentence first, because oftentimes that tells you what they're actually asking. So this is a little bit of a trivia question in my mind. Most people got it, so that's good. But sump syndrome. So this is something that I think we don't see very often anymore because people don't do choledochoduodenostomies as often anymore. I think I have a picture, Dr. Awad, hopefully it came through. Yeah. So I think so. They did a side-to-side choledochoduodenostomy. So on the left there, that's kind of what you see. And the problem with doing that is that the limb of bowel sewed to the bile duct is not defunctionalized. So that means food is coming through it. And so a little bit of food, fiber, whatever can get into the duct and it can clog the duct up. And now that can either cause cholangitis by backing up into the bile duct, or it can also cause pancreatitis. So this is the big reason that we don't really do choledochoduodenostomies anymore, because of this known complication. This can cause chronic cholangitis, cirrhosis, liver failure, all these things down the road. So the right answer when you have a common bile duct injury now is to defunctionalize the limb of bowel that you sew to the bile duct. So that means a Roux-en-Y hepatico-jejunostomy or choledocho-jejunostomy. So I think I put a picture of that too. Most of you guys probably know what that is, but just if you don't, right? So you bring up a loop of jejunum to sew it to the bile duct, and then you bring it down and sew it to the jejunum down below. And I just put a little annotation here. This is really dogma. There's no data to guide us here, but most people recommend a 40-centimeter limb. The reason being, now no food is going to reflux back up into the bile duct because you have this 40 centimeters of bowel intervening that's going to push everything downstream. So that's the whole reason that we do a hepatico-jejunostomy, is to defunctionalize the limb that we sew to the bile duct. All right, a 60-year-old man undergoes routine laparoscopic cholecystectomy for symptomatic gallstone disease. Pathology shows an incidental gallbladder cancer. T stage is T2 and the cystic duct margin is negative. A CT scan shows no obvious disease. Next step in management is observation, chemotherapy, re-resection with right hepatectomy and port site excision, segment 4B5, partial hepatectomy with bile duct resection, with hepatico-jejunostomy and portal lymph node resection, or staging laparoscopy, segment, sorry, my screen is cut off, segment 4B5, partial hepatectomy and portal lymph node dissection. So somebody asked, when do I do Roux-en-Y versus omega loop? I always do a Roux-en-Y. I don't know when I would ever do an omega loop. I don't really know what that is. I need to Google it. Okay, so most people got this right. So the key elements here are, this is greater than a T1B. T1B and above, you need to do something more than just cholecystectomy. So it's a T2, so you know that you got to do more than just a cholecystectomy. So what are you going to do? Right hepatectomy is generally not indicated. That is kind of the old school answer. We don't do that for gallbladder cancer anymore because it's just too morbid and you don't need it. The only reason to do a right hepatectomy is if the right or artery and duct are involved and you're sort of forced to do it. And then the other one has a bile duct resection. So if you have a negative cystic duct margin, then bile duct resection is not indicated. And the reality is, if a patient is jaundiced from gallbladder cancer, they're probably unresectable. So you should almost never do a bile duct resection in a gallbladder cancer unless it's like a really young, fit patient and they like barely have a positive margin at their duct and you think that that's all there is. But if they present with their bile duct obstructed from a gallbladder cancer, that's an unresectable situation. So generally the answer is going to be segment 4B5 resection. And then you should always do a portal lymphadenectomy with gallbladder cancer. So anytime you have gallbladder cancer, portal lymphadenectomy is indicated. So that was the only one that fits that. Staging laparoscopy is controversial for a T2. Generally T3 and above, that's recommended because there's a high chance of peritoneal disease. And then like if you spilled bile on the initial operation, you should do laparoscopy. Or if their tumor markers are elevated, because those are all high-risk features for having peritoneal disease. So
Okay. And for our final question.
I'll try to answer a couple of these.
Okay, yeah.
So, a long one. 68-year-old man who presents to the ED with altered mental status, fever, abdominal pain, and vomiting. After fluid resuscitation and IV antibiotics, his vital signs normalize. He has a leukocytosis of 20,000. His liver function tests and lipase are normal. He is tender in the right upper quadrant with voluntary guarding. Abdominal ultrasound confirms cholecystitis. After discussion of the risk and benefits of laparoscopic cholecystectomy with the patient and his family, you proceed to the operating room. You note severe inflammation of the gallbladder and do not have a safe plane to obtain a critical view of safety. The anesthesia team informs you that the patient is now requiring pressors. How should you proceed? So should you convert to open? Should you proceed with laparoscopic subtotal cholecystectomy? Should you abort and place a drain near the gallbladder? Should you perform a laparoscopic tube cholecystostomy? So Absite default, is the Absite default a portal lymph node dissection? It isn't therapeutic and everyone gets capecitabine. Yeah, so that's way too complicated, Dr. Fong, for the Absite, right? You know, the Absite is written by general surgeons, not HPB surgeons. And I would argue that even in the world of an HPB surgeon, you should always do a portal lymphadenectomy. It's been shown to increase survival, probably from stage migration more than anything, but you should always do a portal lymphadenectomy for gallbladder cancer, even though you're right, it's not therapeutic. Yeah, and I would argue that a portal lymphadenectomy is not a very high risk procedure. There's a couple other good questions here. So this question boils down to the patient is now unstable. How can you get out of this situation as quickly as possible? So taking this sick old patient who's unstable and opening is not going to get you off the table quicker. Doing a subtotal cholecystectomy is not quick. It takes a while. So what's the quickest thing in a patient on pressors to get them out of the operating room is to just put a tube in, right? So putting a tube in is a fine option to deal with their septic source, right? So, you know, this comes down to like surviving sepsis campaign. You need to control the source. You need to drain as quickly as you can. So one way to control the source is take the gallbladder out, but a quicker, easier way is to drain it. And so if the patient's really sick and you gotta get off the table, draining it is fine. So a couple questions, common bile duct injury, when would you proceed with hepaticojejunostomy versus primary pair? So it has to do with a couple things, how big the duct is and how big the injury is. So in a totally normal duct, it would have to be a small injury to repair primarily. And then how is the injury made too? Is it made sharply or with cautery? So in a sharp injury, it's less than 25%. I would say primary pair is almost always fine. In a dilated duct, you could probably be a little more generous, even up to 50%. If you have a big cautery injury, then you have to worry that it's going to evolve. So that would be a situation where you might put a T-tube in and kind of wait and see what happens. Or if you have a severe cautery injury and you know it's injured, then you might just bite the bullet right then and there. But the kind of typical textbook answer is less than 25% you can, and less than 25% without cautery, I should say, you can repair primarily. Most other things will require something more advanced. Gallbladder cancer and HIPEC is a no, at least for now. Gallbladder cancer is very aggressive and does not respond well to chemo, so doing a HIPEC on them is probably not worthwhile. I'm sure somebody in the country has done it and reported it, but I would not do that. IR drainage an alternative for that sick patient, absolutely, but you're already in the operating room. I wouldn't close the patient and then have them go to IR to put a drain in. You're staring at the gallbladder, just put a drain in.
Dr. Vreeland, thank you so much for an excellent discussion and responding to the questions in the chat. We want to thank yourself and all the panelists for really engaging Absite webinar, and this is just part 1 of 2. A couple announcements before we part. Don't forget to join us January 12th for part 2, which we have instituted the last couple of years by popular demand from you all. We're going to cover another array of topics then, so please look forward to joining us. It will be the same format. A lot of you are asking if the webinar is recorded. It sure is, and it will be posted to the SAGE's website in a couple days. The link is posted in your chat box, so please do look out for that. We do ask you to re-register for part 2 so we can have kind of an accurate tally of how many registrants we'll have, as this is one of the most popular webinars we do all year. And then finally, we have a survey that we'll have also posted in the chat. you please take just 2 minutes to click on that survey. It gives us a lot of valuable feedback that we use to make future webinars even better. So please take a minute to do that. The registration for part 2, there will be an announcement that goes out, just like there was an announcement for this one, where you'll be able to register for part 2. All right. Thank you again, really, for joining us. We wish you the best of luck on the holidays. We know it can be a challenging time for many, so please do stay safe, take care, and we'll see you in the new year, hopefully in our January webinar. Thank you all. Good night.